All right, so we're going to talk about successful sacral neuromodulation, and the things I'll speak about in this would pertain to whichever of the companies you prefer. And if you see me say InterStim, it applies to Axonics, et cetera, because they're each really for high quality devices that have good outcomes. So, a couple of things for success. You're going to set yourself up for success right up front by making sure you only offer sacral neuromodulation for the proper indications, and they are urgency and frequency unresponsive medical therapy, urgent incontinence, fecal incontinence, and retention not caused by obstruction. Well, you can read that as pelvic floor dysfunction. So you don't write pelvic floor dysfunction, but if you don't use those 4 codes, you will not get your device approved. So if you have anything else in there like ICBPS, which is the bulk of the patient population I'm doing this in, or pelvic pain, you'll be rejected insurance. So you have to make sure in your office notes you include this, and you include a statement that says, I am doing this for the treatment of urgent incontinence unresponsive to medical therapy, or else you will be insured. Because insurance companies ask for what they refer to as clinicals, which is basically office notes, and so you have to set this up in advance, because trying to get it after the fact is really a problem. Once they've turned you down, they're going to turn you down again. So how to get approval? Only offer it for proper indications. Document all meds you've tried and failed, and generally you have to try 2 for most of the insurance companies in this state. You want to document that you've given advice concerning behavioral therapy. So we'll have a standard dot phrase that says, we have discussed time voiding, we have discussed double voiding, we have discussed caffeine restrictions, we have discussed dietary irritants, we have discussed, et cetera, et cetera. And usually we'll say we've also discussed Kegel exercise and physical therapy. So you do want to document the number of voids, number of incontinent episodes, et cetera. And this is one place where the reps can really be helpful, because they will get a lot of this stuff and they keep records of this. If you don't have what you need in insurance calls, call your rep. They actually have this, because you do have to show improvement on the test phase to proceed on to any final implant. So points to consider. When somebody comes in to see you as a urologist, they've already failed stuff, okay? I tell people right up front, you are probably going to end up with a 3rd-line therapy. I'm telling them that in the first visit, because they've already tried 2 or 3 medications from their primary care doctor. I just have to document that. I don't have to try 6, because they're coming to you as the expert in incontinence, and they expect you to offer them more than the meds they've already tried with the PCP. So give them hope that they can help, and you're committed to doing this, and they're going to want to stick with you. Okay, so what are the discussion points that I have right now with the patients once they've made a decision? So let's say we've decided that we're not, Botox was an option we've discussed. Maybe we've also discussed the possibility of doing PTNS, but they've decided they want a sacral neuromodulation system. So the first is rechargeable versus recharge-free. Rechargeable devices are the Axonics 6-month system and the Medtronic MicroStim. They're clearly smaller, but they require regular attention to charging. Now, there is a new option out there that some people are doing cycling, where they only run their device a few hours a day, so they don't have to charge very often. And there's some talk that Axonics may come out with a once-a-year charging system. Bottom line, though, is that you do have to have patients who are really going to stick with the idea of attention to charging. So for whatever it's worth, I've mostly gone to recharge-free systems that can be set and left alone. They're all fully MRI compatible. Now, the next thing you have to decide is, do I do a staged implant versus a peripheral nerve evaluation? I think you have to really accurately assess the patient to decide. So tips for a successful P&E. Well, first thing, use the reps for pre-test setup and post-test instructions. So you want to get them in there to help you, because they can help your staff set this up while you're going to see other patients, while the nurses and the rep are setting up. Fluoro is helpful but not mandatory. I do really like fluoro, and I have access to it, so I tend to use it, but there's some new technology with ultrasound on the horizon. The best place is to do it in an ASC if you have it. And remember, stack them up and try to do a bunch of these at a time. It's easier for the rep, and it's very cost-effective for you. And just remember, the cost of entry for the patient is really minimal. If they don't like it, you just pull the wire out, so there's really no risk associated with this. So there really shouldn't be a whole lot getting in the way of you offering patients a test to determine if they're a candidate for a sacral neuromodulation. So what about a staged implant? Who do you think's better for that? Big people. Big fat people. If you think you're going to need the extra long needles, you may want to be in an OR or an ASC where they can have access to some sedation. about patients with pain. I do a lot of chronic pain patients, so think of the ICBPS group. They're allodynic. They don't tolerate the P&E needle placement well at all, and so I tend to do most of those staged. And the other group I'll do a lot of times is fecal incontinence patients, because the P&E test is only a 3 to 4 day at the most before the wires tend to fall out, and sometimes they're not having their fecal incontinence every day. So you may want a longer trial, and that with a staged implant, you can test them for about 2 weeks. I use the same crosshair goalpost technique for both, and the thing with the P&E, it takes about 10 minutes, and so as long as you fit in while seeing other patients, it's very cost effective. So let's talk about troubleshooting a little bit. Okay, so you want voiding diaries with the device both on and off, so if the patient's not working, maybe they forgot how bad they were, so turn the device off, have them do a voiding diary for 2 or 3 days, turn it back on. Then we get PA and lateral sacral films, and we do IPG interrogation. So this is, what I tend to do for some of my initial programs. And now you can get 7 programs on the initial setup with the Medtronic device, and some of the more complex programs that I used to use all the time, I don't need to do that very often, but these are some basic programs that we tend to like. Some have better coverage of the pelvic floor. Think of the retention patients may like that. The fecal incontinence patients may like programs 3 or 4 a little bit. Program 2 is a really popular one. Now, the Axonics programming system is a little bit different. They actually will base this on impedance, on the threshold testing in the OR, and they get 2 programs put in. Usually you don't have to mess with that very often. These are some advanced programs. Again, this is using double leads, and I don't do that very often because most of the time with the new devices, I really almost always find the initial programs are good. But double negative will broaden coverage if the nerve runs between 2 electrodes. So sometimes going with a double negative is helpful. You can decrease the kV setting if the stimulation is a little painful, and then if you're picking up a little bit of the S2 or S4, you can also narrow that pulse width. And then I mentioned earlier about trying cycling for preservation. Again, with the longer batteries, it's not that necessary, but it is an option. They can get some people 20 plus years of battery life. So if the patient says they can't feel their interstim, the first thing is most of the time they've turned it off and they don't realize that. So it could have been turned off by a metal detector or the patient's changing programs. So we do remind them, it's okay if it's on and it's helping if you don't feel the stimulation. In fact, it's better if they don't really feel anything. So this is something that what I tell them, it's like putting on a pair of glasses. When you're first a kid and you get your glasses, all you can see is the frame, and then you get to a point you don't see the frame at all. You don't really want to feel this. You do not want to feel the stimulation. Okay, the stimulation is painful. First thing I said is, did you turn this up thinking it would be better? Because it won't. Turn it back down. That's what they do. They all try it. Keep the stimulation on the lowest possible setting, because the higher kV settings cause pain. By overstimulation, it shortens the battery life. You can also narrow the pulse width a little bit. So I'm feeling stimulation in my toes. Now, this is usually from a little bit of overstimulation of S3, so lower the kV setting. And it is normal they'll feel it, so just turn it down a little bit. So if their leg is cramping and they feel it in their calf, that's some S2 stimulation. If you change the program and pull away from electrode 0, you'll tend to get away from S2. You can also narrow the pulse width and lower the kV and salvage that. But that's usually a lead that swings a little bit. It's a little curvy, we call it, and so that bottom electrode tends to touch S2 a little bit. So if you stay away from S2, from 0, usually you can salvage that. So they feel pains or shocks, and just reprogram to use an electrode on the lead as the positive electrode instead of using the case, because that's usually where that comes from. So I feel it in my buttocks, but I prefer vaginal stimulation. Is it working? If it's okay, then leave it alone. But what we can do is if you set the case positive, test all the electrodes, see which gives the optimal stimulation in sort of the perineum scrotal area, then use that as a negative electrode and set your positive as far away as possible. So if the negative is 0, set the positive at 3 or vice versa. Okay, so my retention is proved, but I still have urgency. That's when we might think about cycling, and this definitely lengthens battery life. I can no longer feel my interstim, so we check the impedance. I want to see if the patient, if the impedance is out, they may need revision. Sometimes this occurs if the patient has taken a fall. And again, if they're substantially less than 36 months, I might replace everything, because with the newer batteries, they're going to last a very long time. So I have an infection, you have to explant, culture, treat, and I wait at least 6 months before I will reimplant them. What is important when you're dealing with insurance, there's no need for repeat testing. You've proven this worked for them. They had a successful first stage or P&E, but if they have an infection, you do not need to retest them. They can go straight to full implant. So the device was working. They said they didn't have any fall or trauma. And there's a concept of something called overstimulation where the patient may have just kind of constantly driven that. So I'll turn the device off, wait a little while, reprogram that with new settings and new KV. And that's when sometimes they might get a new battery as well. If the impedance is high, they may need a full revision. Although in this day and age, I'm not seeing that the way I used to. So now the patient says, I've lost weight and I feel the IPG and it's moving or flipping in the pocket. There is a thing called fiddler syndrome. And this is your kind of crazy patients that constantly poke around back there. And I found this thing flipped over like 25 times and it will break the lead. So what you can do with this is you want to do a pocket revision, you incise the back wall, put them a little bit deeper, and then you can actually also put them in the little pocket that Medtronic has that will actually lock that in place. It's like a mesh pocket that's covered with antibiotics and really irrigate them aggressively because there is an increase of infection due to biofilm. So I feel the wire near the sacrum. All right, you can do a tiny little revision over that, but mostly it's okay to leave alone. Just make sure you don't pull that wire too hard against the sacral frame in a thin patient or you can cause some kinking. So sometimes the patient won't feel anything. They're a diabetic. That's okay if they don't feel anything, particularly if they have a peripheral neuropathy. Just base your settings on your fluoro findings and just set them on program 1 at a higher than usual setting, and then you drop it down and it's working, and that should be enough. They may not feel anything. The last one, I have had this happen. When I stand up, I have an orgasm. My question was, how is this a problem? And you're welcome. So that is troubleshooting InterStim in a nutshell.